I just always want to remind you, because I think it helps to kind of understand what we're doing. I don't expect you to know a lot of pathways, and even today, after doing this for all these years, there's things I have to look up. So inherited disorders of metabolism, or inborn errors of metabolism, is a clinical or biochemical. Sometimes we just have abnormal biochemistry and the child is not sick. And it's caused by an enzyme deficiency. The body works on thousands of chemical pathways, and each of those chemical pathways has an enzyme that makes it work. And if the enzyme is missing, then the pathway doesn't work. And what you see is determined by which pathway is not working. The enzyme can be completely absent or partially absent, and that determines what the child is going to look like. Of course, if you have absolutely no enzyme left, you're going to be sicker earlier than if you have some enzyme left. And these enzymes are deficient as a result of a genetic mutation. So these are genetic disorders. The whole basis of newborn screening is that the child's biochemistry is abnormal before the child is sick. And that is the basis of newborn screening, that we're trying. It's not the whole basis of all newborn screening, but we are trying to detect the child, to diagnose the child before they become clinically ill. That doesn't always happen. We have kids who are quite sick in the first 3 days of life. And there's, until we get Star Trek technology, we're not going to diagnose those kids until we have much different technology than is available in 2017. But this latent period where the child's biochemistry is abnormal, but the child is not yet sick, is the basis for newborn screening and metabolic disease. Okay, I want to mention the abnormality is not always an enzyme, but we're not going to really go into that. But it does always affect a biochemical pathway. There are other proteins that can be involved that cause abnormal biochemistry. There really should be some biochemical test that you can do to confirm this. As I said, it's just a screen. So we have to be able to confirm the diagnosis through some kind of testing. And I said we do screen for the full recommended panel. We've not yet added X-linked ALD, but we've really screened for almost everything that's recommended. Okay, so normally you have compound A is converted to compound B, and what makes that happen is an enzyme. And then you have a little bit of compound A being converted to this compound C, just a little bit. But if you have an inborn error of metabolism, then the enzyme doesn't work. So compound A cannot be converted to compound B. And then what was normally a minor pathway, the production of C, becomes a major pathway. An example of this is PKU. In PKU, A, phenylalanine, cannot be converted to tyrosine. And so instead it's converted to phenylketones. And that's how it was diagnosed originally, a long time ago. And so phenylketones, what we call it, phenylketonuria, is actually a minor side pathway for phenylalanine. And of course, the A, B, and C are different depending on which pathway we're talking about. And there'll be a test for you at the end of this to discuss all the pathways. In Alabama, our most common abnormalities are in premature infants. And although, yes, in the grand scheme of things, they're false positives, I don't consider them false positives. I call them expected abnormalities in light of the clinical setting. Preemies are sick, they're on TPN, we know that their biochemistry is going to be affected. And it's really not a false positive because we can interpret it in light of where they are and what's going on with them. But most of our positive results, and Alicia, everybody knows Alicia Roberts, my metabolic newborn screening coordinator. Most of our false positives are due to prematurity, a premature infant being on TPN, that sort of thing. We see a lot of high tyrosine levels, and that's usually it can be due to liver disease, but there's an enzyme required for tyrosine metabolism that takes a bit to mature. And most of our high tyrosines are due to the immaturity of this enzyme. And please feel free to stop me or raise your hand if I'm talking too fast, which I know I do. I'm going to go through today 4 of our most common diagnoses. If you added these up in a year, it'd probably be about 12 diagnoses a year. So we understand when people laugh at that, saying that that's common, because that's not common compared to sickle cell or thyroid, but for us it is common. When Suresh asked me to talk, she gave me a list of what to talk for, and I said, well, that'll take 45 days, not 45 minutes. And I'm sure y'all would love to listen for 45 days. So what I'm going to talk about today is hyperphenylalanemia, And phenylalanine is a mouthful, so I'll call it hyper-Phe. Notice I did not call it PKU. Hyper-Phe, or elevated phenylalanine levels in the blood. MCAD, VLCAD, and galactosemia, and I'll tell you definitions as we go along. This just gives you an idea of what we diagnose. I don't think you can see, but on the left-hand side, as you face it, is 2011, and on the right is 2016. And thanks to Alicia for making this slide for me. But every year we diagnose 4 to 6 patients with hyper-Phe, some of which have PKU and some of which don't. Galactosemia, we can have either 1 to 4, usually about 2 to 3. Carriers for galactosemia. VLCAD, 3, seeming like it's getting to be more. MCAD, several. Carnitine, we see that quite a bit. So we're making many diagnoses a year. But I want to talk about PKU, and I really should have put hyperphenylalaninemia on this. PKU was first described in 1934 by Dr. Folling, who described an unusual compound in the urine of 2 intellectually disabled siblings. And this is really the story of a determined mom and of a doctor who listened to her. And I've got, I hope, on here the reference, because I would really recommend reading this story. It's very moving and very tragic. The first successful treatment was with diet in 1951, and I was not practicing then, although people think I was. And Robert Guthrie developed the test in 1960. He developed the Guthrie card, the blood spots that we use today. Oh, this is the reference, and if you get a chance, I would look it up. It's the story of this mom who persisted in finding out what had happened to her children, who became progressively more and more intellectually disabled with time. I'll give you a second to write that down. The story about Bob Guthrie and developing these spots is he was and you may know more about this than I do, but he was a cancer researcher, and somebody said, Bob, you need to go develop this test. And he went away for 3 days and came back with the test. So I don't know if that's true or not, but he was very involved in the newborn screen, in the metabolic world, which is not a huge world. Okay, so this is, as I mentioned, the phenylalanine pathway. Normally, you have phenylalanine converted to tyrosine, and please notice that little thing in the middle. That is biopterin, which is a vitamin you've never heard of, but it's just a vitamin. Many pathways have a vitamin that makes them work better. And this is the enzyme which is deficient. The enzyme in this pathway is phenylalanine hydroxylase, which is the enzyme that the absence of which causes PKU. So we got phenylalanine going to tyrosine, but the phenylalanine hydroxylase is absent. Untreated PKU leads to the gradual onset, really in the first year of life, of significant intellectual disability. Now, please notice, 2 to 5% of people with untreated PKU are intellectually normal, but 50 to 70% end up with an IQ less than 35. And if you get a chance, you should go on YouTube and search for untreated PKU. As our kids get older, when they can really sort of look at it without being too freaked out, we suggest that they look at it to see what they were saved from, because they really were saved from a life of profound intellectual disability. They often have fair pigmentation for their ethnic group, eczema, and a musty odor, although we rarely detect the musty odor at diagnosis, which is usually at 6 to 10 days. This is the Guthrie test for PKU, and if a patient has elevated Phe levels, the bacteria won't grow and there'll be a clear spot around it. If you treat PKU, and this was one of the first things screened for in terms of metabolism, that normal IQ, compared to age-matched siblings, same IQ. Well, not same IQ, but appropriate for their family. Notice I say for their family. The best outcome is a strict lifelong adherence to diet. We used to think we could stop this diet at age 6 because the brain was no longer developing, but we know that's not true anymore. I don't mean to turn my back to you guys. If you discontinue the diet later in life, it will result in the loss of some IQ points. And I don't know about y'all, but I can't afford to lose any. And you'll also see a lot of mood disorders, and we clearly see this in a lot of our adult patients. But diet outcome in the first few weeks of life will lead to a normal outcome. And it's hard to get people back on diet, and the special metabolic formula which is required is very expensive. We treat for life in our clinic. Now, we have many untreated adults out there that we try to get back in clinic. You know, you see somebody with an elevated phenylalanine level. What could it be? There are very few things that it could be. The primary thing it's going to be is PKU. Remember that vitamin that is required for this enzyme to work? That vitamin has its own special metabolic pathways. And you can have a defect in that vitamin pathway, and that accounts for about 1% of all babies with elevated phenylalanine levels. And an infant on TPN. Infants on TPN are getting amino acids. Phenylalanine is an amino acid. But primarily PKU. There's just not many things that will call, this is our whole differential diagnosis of an elevated Phe level. We had fraternal twins in the last week with PKU. We haven't finished the testing. We think PKU. That's a 1 in 16 chance that mom would have fraternal twins with PKU. So what do we do when we see them? We get plasma amino acids and we get biopterin studies to see if they have a defect in the vitamin pathway, and then they come on over to our clinic. We don't obtain a genetic testing for PKU. We don't feel like it's required. So we confirm the diagnosis, and then we spend about an hour to 2 hours in clinic with them that day, and we teach them what PKU is, how we're going to treat it. The first thing I do when I walk in the room is I say, this is going to be okay. That's the very first thing I say, because they've gotten this call from Alicia, somebody we've never heard of, and they've just had a baby, and now they're being told that there's something wrong with their 6 to 10-day-old baby. So they're completely freaked out. If they've gone online and read about PKU, oh, that reminds me, please do not call this the PKU test. Do not call it the PKU test. It is the newborn screening test. We had a woman call us 2 years ago asking for PKU formula because she was told her baby had an abnormal PKU test. And it was an abnormal newborn screen, but not for PKU. So don't call it the PKU test. So we bring them in, we talk to them, we teach them a lot. Thanks to Julie, one of our PKU moms, we have these wonderful kits that we give out. In most patients, they're either 7 to 14 days old when we see them. We do a washout, so we give them a formula with no phenylalanine in it for however, we get their levels that day, and that determines how long we do a washout, and then we tell them how to mix the formula from then on. And we educate, these poor people just leave in a daze. We bring them back probably in a couple of weeks, and we tell them to please write down all your questions. We give them websites, we give them things to read, because they're just overwhelmed. But the main thing they need to know is it's going to be okay. Now, if it's a biopterin defect, that's not necessarily true, but they don't need to know that day. They just need to know their baby's going to be okay, and that's what we tell them. We do a washout, which is no Phe in the diet. It's only the special metabolic formula. And we change the diet a lot because babies are growing, and we're also trying to determine what each child's Phe requirement is going to be. We give them lots of phone numbers, lots of contact information. We do overwhelm them, but we try to make sure that they have a lot of support from us. Okay, any questions about hyper-Phe or PKU? Okay. I'm going to talk about a couple of fatty acid oxidation disorders. There are about 14 or 15 now. I'm just going to talk about a couple of them, the ones we get positive results back on more frequently. When do we use our fats? Well, I like to say some of us not often enough, but if you look at this graph, and this, as you go from left to right, it's fasting. That's the longer somebody is fasting. So when you first eat your lunch today, for the next couple of hours, you're going to use all the energy from carbohydrates that you got from that lunch. And then after a few hours, you're going to start using some amino acids. And then after a few more hours, you're really going to depend on your fats for your energy needs. And if you're sick, this graph moves down to the left. So if you're sick, you need your fats a whole lot earlier than if it's just a regular day and you're eating. So what does that mean? When do these folks who have a defect in their ability to use fats get sick? They get sick with fasting, but they especially get sick with fasting and illness. If they've got the throw-up bug, if they've got fever and the flu, they're going to get sick. They have altered mental status, often progressing to coma, sudden infant death syndrome, and there's maybe a positive family history, or this child may have a history of just taking longer to get over illnesses than the rest of the people in the family. Excessive alcohol ingestion. Adults have been reported, especially if they drank a lot and passed out in the cold, which increases their metabolic needs, prolonged exercise, a high-fat diet. This is the fatty acid pathway, and fats are labeled by their numbers. You heard some of that with Ann Moser's talk. And these fats go through this pathway, and 2 carbons are taken off every time, and it goes to help the body make energy. That's all you need to know. And the other thing is, fats are where ketone bodies come from. If you've got the flu and you go to the emergency room because you're really sick and you have ketones in your urine, everybody goes, oh, they got ketones in their urine. That just means, one, you have the ability to metabolize fats, and two, you're really sick because you're depending on your fats for energy. So that's a normal response to that situation. These kids go in the emergency room with the flu and they don't have ketones, and they should, because they should be using fats, but they can't. In MCAD untreated. This was one, well, we'll go to that in a minute. They're clinically well, and then they develop some sort of routine childhood illness, often with vomiting. And they may have previous episodes where they just seem to take longer than other members of the family. And then often they're found dead in their beds 1 to 3 days into the illness. Each one of these boxes, this is before screening for MCAD, each one of these boxes is a child with MCAD, and the shaded in boxes is a child who died with their first episode, and the cross boxes are children who were significantly brain injured from their first episode. This is one of my favorite magazine covers, but MCAD was really something that was pushed by parents because they had these perfectly well children who were dying because they were not known to have MCAD. They were dying with intercurrent routine childhood illnesses. But there are a lot of titles on this magazine I like. New Soup Diet, 4 Weeks to a Stress-Free Life. I could do that. Brides over 40. But the main thing here is the simple test that can change your child's life. And it really can. For unscreened, which means undiagnosed patients, the 25 to 30% die with their first episode, and about 32% suffer brain injury. That's unscreened patients. Newborn screening changes all of this. The death rate is 5 times higher in unscreened patients than in screened patients because we don't let them get that sick. So when we get a positive MCAD, we send testing to confirm the diagnosis. We call the family and we initiate treatment with the first phone call, because the treatment is to bring them to the hospital when they're sick so that they can get IV glucose. And we bring them into clinic as soon as we can. But on that first phone call, we tell them what they need to do if the child gets sick, we being Alicia. I'm using the royal we because it's Alicia. When we bring them in, we do the same thing we do with a PKU. We educate them. We give them the fatty acid oxidation screening website. We'd rather them go to a website like that than just do an internet search. We teach them about the genetics, and once again, we overwhelm them, but we try to give them enough resources to look at things. We give them a plan for intercurrent illnesses, and one of the pieces of paper we hand them is criteria for admission. And we say, if your baby has these things, and it's vomiting, fever, diarrhea, then you need to call us and come to the emergency room. We give them an emergency letter that says, to whom it may concern, this patient has MCAD, and you must treat them quickly. You must start an IV, or this patient is at risk for hypoglycemia, seizures, coma, and death. Most hospitals really read that letter and listen to us. Certainly Children's does. And they treat these patients quickly, and we've had a couple of problems over the years, but I think we fixed those. I've yelled at a couple of people, but our goal is to avoid fasting, but really more to avoid fasting with illness. And we also want to provide the appropriate types of fat in the diet. If you have an inability to metabolize medium-chain fats, then your formula doesn't need to have a lot of medium-chain fats in it. So we don't really have a regular diet, but there are baby formulas that have medium-chain fats as their primary source, like alimentum, so we want to make sure they're not on one of those. We use cornstarch. Unheated cornstarch is just glucose polymers. So on mildly sick days, we give them unheated cornstarch, which is kind of sweet, and don't heat it, and they'll drink it, and it gives them some extra sugar calories for the day when they're mildly ill. We give carnitine in most MCAD patients, and we treat illness very aggressively. I always tell the ER, because they'll say, this child doesn't look sick. I said, if they look sick, I waited too long to bring them into the ER. I like to tell this one story. There was a child that died before we were doing newborn screening, and the coroner found a very fatty liver. And this was years ago, and he called, and he wasn't going to do any more workup, but wonderful David Kelly, the head of pathology at Children's Hospital, agreed we could get the samples and do the testing, and we confirmed the diagnosis of MCAD in the child. And I called the mom, and I told her what her child had died of, and I said, is there anything I can do? And she said, bring my baby back. And I've never forgotten that, and will never forget it as long as I live. And that's what we're trying to prevent. We don't want to ever have to do, I don't want to ever have to do that again. So if it's a known diagnosis, we admit for our criteria, which is vomiting more than 2 times in less than 8 hours, fever, diarrheal illness, or anything we think needs admitting. Sometimes we just tell them to come in, especially if we know that they're a more serious form. And once again, if they look ill or if their glucose has already dropped, we've waited too long. So what are we doing when we bring them into the hospital? We're giving them IV glucose. And when we give them IV glucose, they stop trying to use their fats. So we're stopping the use of the defective pathway. We're giving them glucose for their energy needs, so they're not trying to use their fats anymore. We also give them carnitine because carnitine is just a vitamin, and it helps get rid of the accumulated fats. And we're avoiding further dead children. This screening saves lives. PKU saves brains. MCAD screening saves lives. There's not any doubt in my mind. There are some issues which we won't go through today, but alert values, we work up any newborn who has a level above certain criteria, which we have set with the lab. Often it's quite clear that they have MCAD. If our cutoff is 0.7 and their value is 20, well, there's not much question that they have MCAD. But sometimes their values are not as clear cut. And then we need to get genetic testing. But molecular analysis is not covered by Medicaid. And this is not meant to bash Medicaid. We would be lost without Medicaid in this state. I personally can't imagine all the kids we take care of without Medicaid. But we are behind the times on testing that is covered. And we need to get genetic testing on some MCAD. Some we don't need. But on some, we really need it to help determine their phenotype, what kind of clinical presentation they're going to have. And right now, we can't get it. Questions so far on MCAD? So I'm going to switch gears and talk about VLCAD. VLCAD is a fatty acid enzyme that's important for so MCAD is medium chain fats, 6, 8, and 10. VLCAD is really long chain fats, not very long chain, and that's a whole story which we won't go through. But VLCAD is really the enzyme for metabolizing long chain fats. It does 14, 16, 12, and the marker for it is called C14-1. It has 1 double bond. There are 3 phenotypes for VLCAD. Early onset and severe, so these kids can be sick when they come out or sick in the first couple of years of life. Heart involved, liver, hypoglycemia without ketones, and they have a significant fatality rate. The muscles that are involved are muscles that really depend on fat for their energy. So really we'll see a lot of heart, liver, and skeletal muscle. You can have a milder onset in infancy where and we have several of these, where they primarily get sick when they have intercurrent illnesses, and their CK, which is a measure of muscle function, will go up. They can still get a sick heart. And you can have later onset. That were 4 people who presented at boot camp who had never presented before with an episode of muscle breakdown. So that, as far as I understand, I've never been, but boot camp is a pretty significant stress to the muscles. And so they obviously had a much milder form than a baby who presents at 4 months of age. And so they're adults who just present with an episode of muscle breakdown. So how do we tell who's going to have what sort of phenotype? How do we tell what the baby's at risk for? The biochemical testing is not helpful. And in fact, the 14-1, which is the marker for VLCAD, can easily normalize in a blood specimen. We can do skin fibroblasts. So we do a skin biopsy, we send it to the lab where it grows for 6 weeks, and we send it off and test. Well, that's about 8 weeks worth of work. And we get a test back in 8 weeks, which may or may not help us really know the phenotype. Or we could do molecular. We could do genetic testing, because that is the best way to predict phenotype, to predict the clinical presentation of the child in VLCAD. Once again, we cannot get molecular testing on Medicaid patients. Once again, and we can't get it on VIVA patients. We can't get it on several insurance patients without a significant bill to the family. And I'm not here to bash Medicaid. I love Medicaid. They've helped us so much on some patients, but we have got to get in the 21st century with what we do, because we really need molecular testing. And right now we're very lucky that we have a lab that will essentially test them for free, but that's not okay. And I had a lab person tell me, well, these parents need to know what that costs. Do we tell them what 4, 5, 6 CBCs that we test for costs? This is the gold standard for care. The family's going to get a large bill, whether it's Medicaid, insurance, or whatever. And this is 21st century medicine to do genetic testing. And this really hurts our ability to care for patients, both with insurance and with Medicaid. Okay, I'm not just, once again, not bashing Medicaid, love Medicaid. This is a picture of a child, and I can't use the pointer, but if you look at the picture on the left, you can see the whitish part is the walls of the heart. And I'm no cardiologist, but let me tell you, it's very, very thick. This was a little girl that presented before newborn screening at 4 months of age, and she had a very sick heart. All those white parts are the walls of the heart, and they're very thick. We put her on the appropriate diet, which included a lot of medium-chain fats, and the echocardiogram on the right is her heart after we treated her, and it's perfectly normal. The walls are not thick anymore, and her heart functions perfectly normal. And she would have died had we not made the clinical diagnosis of VLCAD and gotten her on the right diet. Okay, questions about fatty acid? We're going fast on this, and there's other fatty acid oxidation disorders that we're not even touching today. Most of them have similar presentations, but these are our most common. Questions so far? Y'all are like, what is she talking about? Okay, galactosemia, which is an inborn error of carbohydrate metabolism. What are some of the different inborn errors of sugar or carbohydrate metabolism? Well, first of all, when we eat, we store our extra sugar in our liver as glycogen, and you can have kids they're not able to get the glycogen out of their liver again. Or there are certain sugars that we eat that we can't metabolize, primarily fructose and galactose. So if you have galactosemia, you cannot break down galactose, and you get sick if you eat galactose. And the early clinical findings in galactosemia are failure to thrive, vomiting and diarrhea, liver involvement, definite liver involvement with coagulopathy, so that the liver makes the factors that make our blood clot, and they don't do that very well with galactosemia. And in the laboratory, they're more prone for E. coli infection, although, knock on wood, I have never seen that. Late clinical, and this reminds me always to say, we've known about some of these things forever, but we still don't know how to treat all the complications. Most girls with classic clinical galactosemia will have ovarian failure. So there's things that we still are not capable really of treating. We send all our girls at about age 8 or 9 to the endocrinologist to start looking at them for ovarian failure, and we've had girls choose to freeze eggs at an earlier age. And we still see some speech problems even in treated patients. Most patients are detected by newborn screening before they're ill, but we've had a few that were quite ill by the time that they were sent to us. Unfortunately, we test this by enzyme, not by the substance. So in PKU, we measure Phe levels. In the fatty acid disorders, we measure the fatty acid levels. Well, in galactosemia, we measure the enzyme level. Okay, we measure the actual enzyme. So if you're a carrier for enzyme deficiency, you have about 50% activity. And if you have the disorder, you have about 0% activity. And sometimes there's a lot of overlap, and we pick up both. We diagnose approximately, on average, 1 to 2 new cases of classic galactosemia a year and many carriers, which is not the goal of newborn screening to diagnose. Patients must be on galactose to be sick. And if they're being breastfed, they'll probably be sicker a little bit later because galactose is a little bit lower in breast milk. Right, Alicia? I don't think she believes that, so we'll take that back. Alicia's not only the metabolic newborn screening coordinator, she's also one of our 3 metabolic dietitians, without whom I could not do this. So we get a result of less than 2.5, which is a presumed positive. So how do we figure out who has the disease? Well, the galactosemia gene can come in 3 ways. You can get a normal copy, which has a normal amount of activity. You can get a galactosemia copy, which makes no enzyme, so 0. Or you can get this thing called Duarte, which leaves you have 2 copies of the gene. So in normal, you get 50% from each copy. With a Duarte copy of the gene, you get 25%. So if you've got 1 Duarte and 1 galactosemia, you've got 25% of normal activity. And those are the kids that sort of get picked up by the enzyme activity. And we don't treat those. I'm not going to go into that right now. We would like to do genetic confirmation because that tells us which one they have. It can separate, it tells us whether they're NG or DG or GG. But instead, because we cannot get molecular testing, we do it based on enzyme activity. I don't want to say it's a guess. It's an educated, what's a better word than guess? So I've measured the enzyme activity, or Emory measures the enzyme activity for us. Soon our lab will be doing it. And this case here has 0, is that what it says? 0% enzyme activity. That's easy. This patient has classic galactosemia. But imagine that that number, so the normal is 22 to 40 something, imagine that that number is 6. Well, I think that's a DG. I know it's not classic galactosemia, so it's not going to change outcome. I think it's probably a DG, but it still could be an NG. If it's 8, it's probably more likely an NG. And I cannot get molecular analysis to determine that. I might could get it if the child has private insurance. 60% of the kids in our state are on Medicaid. I think that's still a correct number. Deanne, do you? 60%. So I can't get molecular analysis to help me determine it. Now, this is not really affecting the child's treatment, but it still is not 2017 medicine. Okay? Same thing as we said before. Medicaid won't approve it. Insurance may be 80-20. Families may get stuck with a really big bill. So the world of lab testing coverage must keep pace with what is necessary and least expensive. Least expensive. That's the key. It's least expensive in 2017. And we have a saying around genetics. We say we're practicing 20th century medicine in the 21st century. And that's not okay. And this saves money. This kind of testing saves money. Okay. Why does newborn screening work? Where am I doing on time? What time? Okay, I'm good. Why do we screen? Well, I've already told you about some cases where we really either saved the child's brain or we saved the child. There's just no doubt that we're saving lives. No doubt in my mind whatsoever. Yes, we have unanswered questions. We started this without having all the answers, but that's okay. We'll get them as we go along. We followed 2 women who were born in the 50s who had untreated PKU. One of them has since died. And that was the first time I've ever seen an untreated PKU patient in real life, and it was profound. They walked, they had no language, and they didn't really even recognize each other. And it just showed me why we do this. And that's why I want the teenagers particularly, who are getting on their own and eating on their own, to see these videos of what we save them from, because it's very important. And we certainly detect it early enough that we've saved them from any brain damage. Parents are always asking, did we do it early enough? Yes, we got it early enough. MCAD, I told you the story. We don't want to ever tell that story again. Treatment, and most of these things, we have very specific treatment. We know how to treat. We know how to monitor. In PKU, we treat by restricting protein, and we supplement with special metabolic formula. And as I said, the lady that called us and said she had an abnormal, so we had this lady call us and say, I need some PKU formula. And we said, why? Because we hadn't gotten a positive result. And she said, well, my baby had an abnormal PKU test. Well, her baby had positive screening for cystic fibrosis or something, not PKU. And had the baby gone on this PKU formula, it would have been quite dangerous. So once again, a reason not to call it the PKU test. Don't anybody in here ever call it that again. I don't mean to pick on anybody, but just don't call it that again. So we have special metabolic formula, which most people in their adult years cannot get, but they still need. We showed you the study where they can lose IQ points. With MCAD, the treatment is treatment with intercurrent illnesses, come in the hospital for IV fluids. So I want to talk about a couple of current problems in newborn screening. Too many repeats. Who in here is guilty of that? Oh, come on, guys, raise your hands. Everybody's guilty of it. Too many repeats. And this especially is true in nursery babies. And if you do a test often enough, something's going to come back abnormal. Alicia and I've seen at least 2 this week that had 7 newborn screens. And on the 7th newborn screen, the carnitine was too high. Well, we know it's not anything, but we had to work it up. So if you have a positive, just do what we consider the gold standard. If you get a positive for galactosemia, do the enzyme test. If you get a positive for a fatty acid disorder, call Alicia. Her number's up here on the next slide. She threatened me, but I put it up here anyway. You want to do the real test. Don't send another newborn screen, because something's going to come back abnormal that really shouldn't, that is not abnormal. If you do 7 tests, something's coming back abnormal. No baby should have 7 tests. We have an NICU protocol that says you get the screen and as soon as the baby's admitted to the nursery and something off TPN, but it never says no, anybody should have 7 newborn screens. Don't do it. And the other thing is we get people who send the incorrect confirmatory test, and this is Alicia's number, which I'm sure she's happy that I'm posting. But she knows what to do. I mean, she's got all our protocols. She knows what to test for. She knows where to send it. So just call Alicia, and she will tell you where to send it. Now, you can page me at night, but I'll be like, we got to wait till in the morning when I can talk to Alicia. And Alicia. Yay. And that reminds me to say, we have a whole team of people that do this. It is, I'm the one usually up here talking, but it's not just, by any means just me. We have 3 doctors taking care of these patients, 3 metabolic dietitians, and 1 nurse. And we couldn't do it without the whole team. Our other current problems is inability to get genetic testing, once again, not just through Medicaid, but through insurance as well. And it's not just true of the ones I discussed, but for other ones as well. Sometimes you don't need it. I don't need it to diagnose PKU. But I do need it to help decide what kind of presentation a VLCAD patient is going to have. Here, I said it again. Don't call it the PKU test. I'm not picking on you. I'm sorry. Okay. I mean, this happens all the time. All the time. I've yelled at many pediatricians, you know, because they call me at night and say, my kid had abnormal PKU test the carnitine or something. I'm like, no, please. So those are some of our problems. We would really like to get some of those things worked on. And if you have questions, call Alicia. Thank you. Thank you so much.